So why apart from so many books, video, online programs, YouTube video, and so many things, why people not able to get command over ECG? Can anybody tell me? See in a book the ECG like this. This is just a funny type of image. You look in a if you read some book or watch video, you look at some kind of particular pathology. It's well a Photoshop pathology, and you think that it's very easy. Okay, but when you go to clinic, all this scenario is very different because every ECG can come with multiple findings. It's not like that you have today you have learned the complete heart block, and next day it comes with the by Gemini with a heart block or MAT with a heart block, complete heart block. So there is a lot of combination. So we have a collection of more than 100 of ECG that we are going to cover during this program, and we are starting from the very basic, like what is calibration and rhythm lead. This calibration is nothing but the setting of the ECG machine. It could be altered by technical staff by some cleaner who can mistakenly click, or if you are not aware of this setting, you can may also click on this, and what we will find, we will kind of bradycardia. And I have noticed, I posted in the group, and people were saying, yeah, give him atropine, give him pacemaker. I think first make an habit. This is the calibration. 25 millimeter per second represent the rotating speed of the ECG paper. Okay, so first check this calibration. 25 millimeter per second is the rotating speed of the ECG paper, and 10 millimeter volt per millivolt is the voltage applied. So suppose if the speed of rotating ECG paper is 25, is the normal, is the standard. Suppose it become double, 50, as I posted that day. What will happen? ECG will move like this, okay, and that pen of the ECG machine will tap like this. If it moves at a higher speed, it will tap at the larger distance. So RR will be separated widely. So it will apparently look like a bradycardia. If speed is double, then calculated heart rate, whatever will be, we have to double it. Okay, if it is 37, then we have to double it, 35, or we have to double it, 37. Okay, so this is very important. Or suppose if this voltage, can you see this, or should I zoom it more? Volt. So if the speed is double, the voltage is double, then the complex will be of the double size. You have to remember this. Okay. So next thing, in ECG, you all know that there is a horizontal coordinate and there is a vertical coordinate. And we know that in the horizontal coordinate, we measure the interval, time. Okay, time, PR interval, QT interval, like that. And in the vertical coordinate, we measure the heights and depth of the waves, heights and depth. Okay, so we are going to start from very, very basic, as I told you. So please look at the ECG paper. This is a small square paper, small square. And in the horizontal coordinate, one small square is equal to 0.04 seconds. Okay. So if suppose, I will tell you later on how to calculate. Right now, just remember this. But in vertical coordinate, one small square, this one small, I have zoomed this. Look, this big square, I have zoomed. So one small square will be equal to 1 millimeter, because we have to measure the dimension of length. So it will be in the millimeter. And when we have to interval means time, we have to measure in the second or millisecond. Okay. So these were the about small square. Now let us understand how to calculate the PR interval. Okay. So suppose we have to calculate the PR interval. And the PR interval is calculated from the very beginning of the P square to the R wave. Okay. So how will we calculate? We will calculate number of small square between P and R. So I have marked with the red squares, small square. So it is 1, 2, 3, 4, around 4. So we know that 1 millimeter square, one small square is equal to 0.04 seconds. So here we have 4. So 4 multiplied by 4 will come out to be 0.16 seconds. Okay, so it's very easy now. But when you will calculate now, then many times you will get problem. Because in WPW syndrome, it is short, but until unless you practice it only, you cannot make it out very clearly. So next is, I'm just giving you idea how to calculate the interval. Similarly, you can calculate the QT interval and QT other interval. And for QT, you have to do a correction, make a QTC, because QT interval variate with the heart rate. If the heart rate, then will be bradycardia. If a person is walking or doing exercise, his heart rate become faster. So we can understand that. That is a normal physiological process. But QT interval will also vary. But that doesn't mean QT interval gets shortened. That's why we have to use a Basel formula for correction. Most of you might be know about that, but we will cover that during the program. Now, next is rhythm lead. So one question I would like to ask you. This is the rhythm lead. In every ECG, it is get traced at the bottom of the ECG paper, as you can see. So what is significance of rhythm lead? If we have lead 2 here, then why lead 2 here? Then why we are this? What is the use of this long lead? Can anybody tell me? Just type down significance of rhythm lead. This is a rhythm lead, long lead at the bottom. Okay, in case of Dr. Akhil Tripathi say in case of irregular rate. Yes, very good. To check for the blocks. Yes, very good. For the rhythm and blocks, we need a long lead. Okay, we cannot check the rhythm with a short 2, 3 or 2 beats. Because in Wenckebach phenomenon type 1 AV block, Mobis type 1 AV block, what happened? There are gradual prolongation followed by drop. So we need a certain number of beats. For number one, for checking the rhythm is irregular, that's okay. But also for the checking the rhythm blocks and complicated rhythm, we need a long lead. Without that, we cannot comment on anything. So remember, let us discuss about how to calculate the heart rate. So method of calculation of heart rate is different in regular and irregular rhythms. So when I say regular rhythm, that means these RR waves are separated at the equal distance or equal small square or big square, as I have shown here. Okay. So this is the regular rhythm. As you can clearly see, even by judgment, even you don't have to calculate the number of square. Even by just judgment, you can check that this rhythm is regular. So in regular rhythm, it's very easy. What you have to do, you have to calculate the number of big square appearing between 2 R waves. Okay. Sometimes here I have calculated there are 1, 2, 3, 4. Sometimes it could be 3.5. So you can make it 3.5 and accordingly, according to your understanding and mathematics, then you have to calculate number of big square. So number of big square is this 1, 2, 3, 4, and just divide it by figure of 300. 300 is a constant. Okay. So you have to divide it 300. So 300 is derived from the physical derivation. Those engineer might have this design that if there will be that much big square appearing, that so there is a proper derivation. You don't have to do anything. You just have to remember the figure of 300. If rhythm is regular, you have to divide the number of big square with the 300. In hurry, we are not going to calculate small square because and so here if you see there are 4 divided by 300, it come out to be 75 beats per minute. So it's very easy. But don't forget to check the rhythm before that. Now this is the irregular rhythm. Even a beginner can tell that these RR waves are separated at the different distance, as you can see here. Okay. So you can see. So what you have to do, you have to take 30 big squares. Just you can start from here to here. So I have started from here. So 1, 2, 3, 4, 30. So I have calculated 30 big square. And what then I have to do? I have to calculate the number of R waves appearing between those 30 big square. Okay. So here I have number of R wave appearing is 9. And we have to multiply 9 by the figure of 10. Again, 10 here is a numerical derivative. It's fixed. Okay. So you don't have to think about that. So what you will do, whether you start measuring for here or there. So what will be the result? Since it's an irregular rhythm. So you will be, you can mention it in a range. Like if suppose here I have calculated, so it is a 90 to 60 BPM. So you can take it plus minus 10. Like heart rate is between 80 to 100. You can write this because this is irregular rhythm. Okay. So this is how we can calculate the. Next is axis deviation. So friends, although this method is for guesstimating. We teach during our regular session, we have created a video and we teach how to calculate in the degree. We don't accept these kind of guesstimations because it could be true, it cannot be true. Okay, so let us just for understanding purpose, most of the time, lot of time it would be correct. So here we can see leaving peaks. Okay, the peaks are leaving each other. If you see in lead 1 and 2, remember 1 and 2. You can check the peaks are leaving. Look at this R wave. It is going upward. This is going downward. So the peaks are leaving. L for leaving, L for LAD, left axis deviation. Just for remembrance and guesstimating, you can remember this like this. Okay. So in RAD or right, these peaks are reaching each other in lead 1 and 2. You can see here. So R for reaching, R for right axis deviation. These methods are just for guesstimating, and I'm just telling you because I have created a video. It will take 30 minutes for understanding. After practicing session, it will take another 1 hour. So because in our program we go very deeply. Okay. So this is the demonstration program. Here I cannot teach you in very detail, and just I can give a superficial idea. You can keep your pen and pencil with you. You can note down. Okay. So next come the fatal arrhythmias. Arrhythmias of cardiac arrest. Can anybody define cardiac arrest? Heart stop working. Actually, these are the, although you may be, but these are not the standard definitions. So let me tell you, you can write down. According to AHA, okay, Health Association, or there are 3-word standard definition of a cardiac arrest: unconscious, non-breathing, and pulseless patient. Unconscious. If you see some patient is unconscious, shake him. He is not responsible. Means he is unconscious. Check his breath or movement of chest, non-breathing. And check his carotid, pulse, no pulse. Just 3-line definition is enough and standard. If you told this, there will be no cross questioning in Viva or anybody. So pulseless, non-breathing, and unconscious patient is considered to be as in a cardiac arrest. Okay. Have anybody done a course of ACLS, BLS? What happened in ventricular tachycardia? Some focus on the ventricles become irritable and develop the capacity to generate the impulse. Usually in ischemia, it happens. Okay. So what happened? Now, previously, what was happening? The sinus node was firing, impulse was coming from the AV node to the ventricle. Now, what is happening? The one foci get generated over the ventricular wall, and since it is it doesn't know anything about what should be the rate and what should be the rhythm, it started firing like anything in a very fast manner. So, what is happening? Before the normal impulse will not get traced, and this new foci will fire, and the heart will depolarize at very fast rate and will contract at so much fast rate that it will not be able to receive the blood from the artery, not able to even contract the blood. So cardiac output will be 0. So sometimes you may find the patient with VT with pulse. So clinically, we can differentiate the ventricular tachycardia into two types: pulseless VT and VT with pulse, with feeble pulse. So we are not talking about the VT with pulse here. We are talking about the life-threatening arrhythmia or cardiac arrest. So here we are talking about the VT, pulseless VT. So I so let me show you with an animated video. Now you can see some foci firing and these ventricle are contracting, and the normal sinus rhythm is getting suppressed. So what will be the feature on the ECG? So we will find characteristic ECG features are regular tachycardia. These are not the QRS complex. Most of the people do a mistake that broad complex tachycardia. No, these are not QRS. Here, PQRST get fused to form these kind of weird shaped broad complex like this. So here the heart rate is very high, and you can see these kind of broad P, T, QRS, everything get fused, and we can see there is a very high rate. So it is very easy rhythm to recognize. VT is very easy rhythm. And now let us talk about sustained and non-sustained ventricular tachycardia. So let us not talk about theory part. Let me tell you, demonstrate with the video. You can go through this, read it. I will demonstrate with the video, real patient video. Here you can read the non-sustained VT, ventricular tachycardia defined as more than 3 beat, blah, 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 last for 30 seconds. Okay, that is the theoretical part. But what are going to, this is not going to help you in the clinical scenario. And now this will help you. This thing will help you. This is normal sinus rhythm. Now look here. Look here. These VT complexes suddenly appeared. And as I resume the plane, it will get resolved. So VT appear and gone. So it was a non-sustained VT. Have a look at again. Look. This is non-sustained VT. But this is the alarming sign that after some time this patient can go into cardiac arrest or VT. So 4 or 5 8 for 30 seconds, that is the criteria. But now you have a picture inside the mind what is going to be happen in the. So this is more helpful. Okay, if you in ECG, if you see normal sinus rhythm followed by 4 widespread 4 broad complex ventricular tachycardia, and then ECG revert back to normal sinus rhythm, then you will say this is non-sustained VT. Okay, and so what is you will see here? First, normal sinus rhythm is there. PQRST. Look, same patient after some time develop this VT. Now it's not getting reverting, not reverting back. One of the most important and malignant form of the VT is Trossard day point. What happened here? Here the axis changes by 180 degree after every spikes. So after few spike, it will change. After few spike, it will change. So it will, if we see, it will give a ribbon party shaped appearance or twisted ribbon appearance over here. Okay, twisted like this. So you can see Trossard day points. So now let us, these were the bookish knowledge. Now let us see how it really appears in clinical scenario.
Trossard same points.
Now look here carefully. Let me mark this. If you see, I'm marking So this is same twisted party ribbon shape. Look. So in clinical scenario, things are very, very different. So you can see this is the Trossard day point. On cardiac monitor, you will find usually it is self-reverting rhythm. Now let us move toward the ventricular fibrillation. Please have a look. Please check this video and share your review. What you can see here. Here you can see instead of contraction, there is a quivering of heart. So how it's happening? Previously in ventricular tachycardia, I have told you that either one or two foci is firing. Okay, that's okay. So one foci was firing. It was depolarizing the ventricle before, and the normal sinus rhythm was getting suppressed. But in ventricular fibrillation, what is happening? There are a lot of foci below. So lot of foci, if they will fire, that there will be asynchronicity. So there will be no net depolarization. In ventricular tachycardia, there was a depolarization of ventricle. But in this ventricular fibrillation, there is no depolarization. So heart will not depolarize, it will quiver. It is not even contracting, it is quivering. So their cardiac output will be zero. Okay. So now look at this video carefully. Here you will see here, you have to put attention over this part. You will see multiple foci are firing like bulb, small bulbs. Na? Look, you can appreciate, I think, very well. Now see, lot of foci are firing. So what will happen? There will be no net depolarization of ventricle. And on ECG, what will you see? Nothing, just fibrillatory waves. These kind of just as if some children have drawn irregularly up and down strokes, some kind of this. So this is the VFib, ventricular fibrillation, very easy to understand or recognizing the ECG. And asystole, everybody know, flat line. But don't do mistakes. But what happens sometimes, lead get detached. So don't get confused with that. That patient gone in ventricular tachycardia. This usually happens. So next thing is pulseless electrical activity. You will not find any excellent good definition in any book with understanding. Today I will make you understanding this. This is also important. So apart from VT, VF, asystole, AHA have given a this fourth rhythm as a cardiac arrest rhythm. What happened in pulseless electrical activity? There will be cardiac arrest, patient will be unconscious, non-breathing and pulseless. But still there will be a cardiac electrical activity, normal electrical activity. So how it's possible? Think. So let me tell you with an example. You might have heard about cardiac tamponade. So what happened due to some injury or some other reason, like other reason also, and what happened? This pericardial sac get filled with the blood due to some reason, maybe due to trauma. So what happened? It compress the heart. So it strangulate the heart to a non-contractile state. Non-contractile state means it will not be able to either relax or contract. It will get suspended. So what will happen? Here conduction system is normal. P wave will, SA nodes will be firing. There will be P wave, there will be PR interval, QRS, but heart is suspended. It is not able to contract. So there will be cardiac arrest, but there on immediately you will put the lead and you will see a normal sinus rhythm, tachycardia, normal tachycardia or normal bradycardia in the cardiac monitor. So in that case, you must get immediately, you have to decompress this pericardium. Okay. So another condition is tension pneumothorax. Sometimes if there is chest injury due to tension pneumothorax, the air collection of air inside the uh, this thoracic cavity, it compresses the heart to a non-contractile state. So a lot of people do a mistake that they call the cardiac tamponade as a pleural, confuse it with the massive pleural effusion finding or electrical alternate. No, that's not correct thing. Strangulation means heart is suspended. It's not able to. I'm going to compare this with the pericardial effusion so that you in future you should never get confused between two. So strangulation means heart is non-contractile. It can happen with in hemopericardium and tension pneumothorax. Two main important reasons. And other one is pericardial effusion. So in pericardial effusion, what will happen? There will be gradual collection of the fluid. So the pericardium will get gradually expand. So there will be no such kind of strangulation in the pericardial effusion. If you see, look at this clip. Here you can see this is the heart. It is beating, and you can see this is the surrounding hypoechoic area. This is the fluid. So now here a fluid, the heart is hanging inside a fluid-filled cavity, pericardium. So this is a massive to moderate to massive pericardial effusion is there, and heart is contracting, able to contract, though there is no such pressure because it develops gradually. Okay, and in trauma, it immediately develops and it doesn't give time to the pericardium to expand. That's why that in hemopericardium there is a tamponade. But pericardial effusion develops gradually, and the rapidity of filling that decide whether it will go in a arrest or not. So in massive pericardial effusion, you can see heart is suspended, and now here I would like to tell you one important thing, very important thing. What are the ECG features of this electrical pericardial effusion? Is electrical alternate. So what will happen? Suppose heart is here, okay? So it is suspended. Now what it is also contracting, and as it is hanging inside the large pericardial sac, so it can also move to and fro, to and fro. So when it will come closer to the anterior chest wall, so it will generate higher amplitude of QRS complex. And as it moves posterior to anterior chest wall, it will generate lower voltage. Why? Because we place the chest lead over the body now. So fluid, if it go away, so it will be there will be lower amplitude, lower voltage we reach to the chest or body. So as it moves away posterior to anterior chest wall, and as it come closer, it will generate high voltage amplitude. So a typical rhythm will be seen in the electrical alternate. Let me share. So now you can see here very clearly, make it clear. Okay, you can see alternatively high and low voltage QRS. We called it as electrical alternate, and it is seen in massive to moderate to massive pericardial effusion. Okay, so very important thing you must learn. So let us discuss about another common rhythm, atrial fibrillation. Okay, so look carefully. If you have conceptual study now, you will never forget ECG. You will never done a mistake if your concepts are crystal clear. So look here, what is happening? Now look, what's happening in the atrial fibrillation. Previously, we know that SA node fire and there is a normal conduction. But here, lot of foci are started firing due to some vision pathology. Okay, as you can see here, lot of foci started firing, and the normal sinus impulse is not getting inhibited. And as this lot of, as I told you in ventricle fibrillation, but that is the different thing. But here, what is happening? There will be no net depolarization of atria. There will be no contraction of atria. So in atrial fibrillation, there will be no depolarization of atria. So depolarization of atria represented by which wave? Tell me, type down please, fast. Depolarization of atria represented by which wave? We have just completed. P wave, Viren, Aisha, good. Yes. So what will happen to P wave? Anupriyatam Koyaka. Okay, good. So what will happen to P wave in atrial fibrillation? Yes, absent, Mahima. So with conceptual study, we can learn that there is no depolarization, so P wave should be absent. But here you can see P wave will be not there, but another thing is there. Irregular impulse will reach the AV node. As there are so many random impulses, some of these waves will reach the AV node, and AV node will conduct it like a normal, okay, in an irregular manner. So the QRS generated will be normal because they will not get affected. So what will be happen? There will be no P wave. So irregular impulses will passing through AV node. So the rhythm will be irregular. So here we understood with conceptual study that the P wave will be absent and there will be irregular rhythm. So now it will become very easy to understand. So whenever you use any rhythm which is irregular and there is no P wave, it's atrial fibrillation because you know P wave is not seen. Although there are a lot of other rhythm like junction rhythm and some other rhythm also where P wave is not seen. But right now we are not going in that. Just learn simple thing. We are talking about AFib. If the impulse, there are a lot of things to differentiate AFib with those. So impulses are irregular and no P wave. This is atrial fibrillation, very common rhythm, very common rhythm, and don't miss this rhythm. Okay. Now let us discuss about atrial flutter. What happened in atrial flutter? Let us first understand. Before going to the flutter wave or that, let us first understand. So look carefully at the video at this part. First, there will be normal sinus rhythm. Then this impulse will start rotating inside the right atrium. Let me play this video and focus to this part and watch carefully. Remember, as you can see, you notice now the impulse started rotating in a circular manner here. So due to some pathology or some fault, these started rotating in a circular manner. Okay. So like re-entrance pathway like. But still, this rotation, what will happen? This both atria will get depolarized here, but at very high fast speed, and P waves will fuse to form flutter waves. I will show how they look, and atria will fast at much higher rate, 4 times or 2 times than the ventricle. It is firing, contracting depolarizing atria, and as well as some impulse will get passed into the ventricle through AV node, and they will produce a QRS, normal QRS. Okay. So what will be the picture? Sawtooth shaped wave, ECG wave. Okay. Sawtooth shaped ECG wave. So here we can say these are the 1, 2, 3, 4. So 4 flutter waves are there, means atria is contracting 4 times faster than the ventricle. After depolarization 4 times, one impulse is getting passed into the ventricle and producing one QRS. So here you can see. So atrial flutter could be a regular rhythm or it could be a regularly irregular. Let me show you in the next slide. So here it is regular, perfectly regular with 4:1 conduction. Don't confuse these conduction with AV block. Okay. So we will call it as atrial flutter with 4:1 conduction. A flutter with variable conduction. What will happen here? Here you can see two flutter wave followed by one QRS, two flutter wave followed by one. Here we can see 4 flutter wave followed by one. So here 2, 2, 2, 4. So rhythm will be regularly irregular, not irregularly irregular like AFib. It will be regularly irregular. So with variable conduction, 2:1 or 4:1. Here 1, 2, 3, 4 followed by one QRS. So atrial flutter could be of 2 types, and these flutter wave form due to fusion of P waves. Okay. Now, friend, for discussing about AV node, let me tell you one thing important, that a lot of doctors have struggled throughout their life, read so many books, and in the olden time there was not so much advancement of the technology. So we have a lot of elder doctors who have joined my program, and they finally thanks from the heart that finally after so many struggle, finally they learned from ECG from our program. So that's a great thing for me. One is this doctor is 67-year-old sir, and this is the retired major from Army Medical Corps. And let me show you the video feedbacks of the book. This is why this is important. If you think that you will learn by yourself, okay, keep learning, keep doing. Nobody is going to stop you. But lifelong you will remain dependent on others. Will not able to get confident, because just by suppose you read some subject and other day you go to the clinic, is it some kind of guarantee that you will get same pathology? No. But our program gives this guarantee. We will teach one pathology and we will next day we are going to be give you ECG, real clinical ECG of same pathology with variations also, variations. So immediately what you have learned, immediately you will catch and become expert. And in the last of the session, we conduct rapid fire session, exams also, tests also. So overall practice will make the person perfect in ECG. So I know the people who don't want to join the program will hesitate to see this video, but this is for those people who are genuine people here who want to learn the ECG, not for those people who want to just for the free demo मिल जाएगा तो चलेगा. So आप लोग people come join my program. If they see my ad, they immediately click because they know every time I will teach them. But I don't care about it because with this demo session, nobody going to become perfect. So you can come 100 times. I don't have any problem.
Hi everybody, I am Dr. Uttam Kumar Gangopadhyay. Just celebrated my 67th birthday a few days back. A permanent dweller of West Bengal, living in a small city near Kolkata. I am here addressing my respected teachers, Dr. Amit, Arora and Dr. Ramandeep Verma, along with my fellow participants who are along with me in the ECG training course conducted by my teachers in WhatsApp. Suffice it to say that I am undergoing this course for the second time. First time being about 2 years back. So it is a very nice and unique course. No need of consulting any books or journals. Just following this course rigorously, it is sufficient. One will make the diagnosis permanently and confidently. Some of the students are very nice, and I
Doctors and my friends, good day. Hope you are all in good health. It's my feedback on the course attended in WhatsApp MCC. I am Major Shekhar Narayan Swami of India Siemens, Occupational Health Physician and Chief Medical Officer by profession. And I wish to inform, I had previous interactions with the MCC, that is Medical Case Consultation Group in Facebook, long back, but I had an exposure with the WhatsApp learning of MCC group recently. Though I am senior by age and at the verge of retirement, learning ECG is my passion, and this group heartily helped me. I attended online MCC ECG learning program and subsequently COVID radiology program too. That means MCC radiology program. Regarding both these courses I attended between July and November, each lasted approximately 1 to 1.5 months, 1:30 p.m. except Sundays. Practical things to clear our doubts, make us understand radiology in general as well as ECG, emergencies, especially like head injury, CT chest, to understand. I am sure you will have such a beautiful exposure, and it's worth learning. And when you see ECG traces, X-rays, and of course CT, though my profession doesn't allow the luxury of spending 5 to 7 p.m. leisurely, I used to be late on every day, but I never missed a single word. Why? Because they all are preserved in WhatsApp chat, as chat, pictures, audios and video clips. So most of the time I can repeat the thing till I understand. It is childish enthusiasm, and that helped me a lot. I particularly enjoyed Dr.Amit Arora, the main pillar of the MCC group. It is childish enthusiasm in conducting the classes and his witty comments and
So, friend, you might have seen that a lot of people have joined our program. They were interested, not due to not much advancement of technology in the previous time. So, finally, they learn ECG from our program. So, if I start showing you, it will become midnight. I have so many feedback uploaded on the YouTube. You can go and check and analyze the quality of the program. So let us discuss about AV block. So firstly, let you. So how many of you are interested to join our program? We are going to start on the 15th. So how many of you are interested to join? So you have seen all after this Zoom session. So after this Zoom session, yes, Dr. Mahima say yes. Okay. So Dr. Amit Kumar is saying, my name is Amit. Yes. Dr. +1, Akanksha want to join. Anurag want to join. 1+80 want to join. Akul want to join. Aisha want to join. Interested. Want to know more. Interested. Okay. So you have my number and my coordinator, Dr. Hari Prasad, and my technical team who are approaching you through various platforms, giving you. Okay. So you can either contact me directly. You can make payment. There's a simple procedure, and immediately I will give you access, and I will add you in the program group. And any of the member here who have already joined our program, maybe in the both group and joined again either. Anyway, so the most one thing I must tell you, the most common thing that will resist you is your mind. It will say that no, I don't have any time. What will happen if I miss the lecture and what blah 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 blah. Let me tell you that this program is not for undergraduate MBBS students. They are not going to learn ECG. This is only for practicing doctor or doctor who are doing MD or who are practicing for many years. And we have designed this program in such a way, even if you miss some this session, lecture or practice session, you can easily catch up on. We will give you lifelong access to our website. You can read the theoretical part. That is not a theoretical, that is a notes prepared by me, prepared those slides by me. And in one slide, it will cover complete lecture. Those kind of slide I have prepared, and I have made notes like theory part. Short, and there are tutorials, very descriptive. That I have just gone through and told you everything. You can't remember everything. You need chart, you need those videos, those they have gone. Okay, so it's like this. There will be a 30 or 20-minute hardly video, and it will cover a lot of things. And then you, in the same session, same lesson, next theory session, you can go through that theory part. And then next day, there will be a practice session on them. And then you will gradually develop confidence. And after this 30 to 40 days of journey, you will become master in ECG interpretation. I have students who have just resident, but now they are even discussing the ECG with their consultant. Even MD3 asking them, I have video feedback, asking them from where you learned. So previously we used to teach on the WhatsApp, but now we have shifted our platform to Zoom and website also. But main platform is WhatsApp, where we conduct two-way interactive session and you can post. It is very difficult to convey everything if we conduct weekly Zoom session. You will remain in contact with me 24 hours. Okay. So most of the doctor make a common Dr. Viren here, please inform us procedure, how to join full program. Nothing, just inform me. Just how to join the program, just nothing. It's not some kind of you have to full the you have to submit the document or like that. It's a mutual understanding program. You just message me, I will give you payment link. cost of the program is 3,800, not even 1 rupees less than that, because I am not going to doing marketing over here like other people do. They will tell you that our course costs rupees 10,000, and if you join right now, we will give you 50%. They are doing marketing here. I have my own setup. Teaching is my profession. I am not. 3,800 is just for all the maintenance of website, creation of website, and also my time. I will be going to spend the time weekly with you. On the WhatsApp, I will be conducting practice session, or some of my colleagues will conduct. That's not matter. But every member can ask me personally, what is this, sir? So member who have already joined and completed 2-3 chapters up to 5 chapters. And some of the, I think there is a member from US, I think Stella. She has completed almost 90% course. So from 15th May, we are going to start this program. After that, for 30 days, we are not going to conduct any Zoom practice session, nothing. We will concentrating on only those people who have joined the program and will focus to make them expert. So timing is not any issue. Okay. So before we start AV blocks, I will give you surety. If you learn today AV block, you will never forget for the lifelong. I will teach you in such a manner. But before that, let me share one more thing, important thing, which is remaining. That is timing. Most of the people, doctor, have a common thinking. Their mind say that, oh, I have a very busy doctor. When we will get holiday, we doctor, we need holiday. When we go to holiday, then you are going to join this program. No, we doctor have never time for upgrading our knowledge. But due to advancement of technology, we have this opportunity to learn in a two-way interactive manner, that too in a virtual classroom. It's not like individual study. I'm checking everybody and paying attention, and those practice sessions will be conducted inside the group. That batch will be group. So I will be keep on checking, and there will be a classroom-like atmosphere, and timing will be never a problem. So let me share one last video with you people.
Hi, Dr. Amit and Dr. Ramandeep. I'm Dr. Neeraj Miglani here. Thank you so much for such a wonderful ECG session, which you had taken ECG classes for the entire month. I'm sorry I could not attend the session live, as I had other appointments to finish during those hours, evening hours. So, but I always used to catch up in the morning, study, just like in my college days. And but it was really, really, really beautiful. We have been seeing ECG, we have been treating patients, but the way, the details you have given during your classes is amazing. Now it's so clear. And definitely now what the message we have got, that you will star mark all the days and how to revise, that will be really helpful, because every day I was definitely scrolling back, and then during the practice session I was checking myself, where do I stand. Very helpful, even for the newcomers as well as for people who have been practicing like us for many years. ECG.
Somebody asking to share the number. On my all videos, my number is shared on post. Let me share my number also. You can note down. This is, you can WhatsApp me. 9915162832. 9915162832. Okay. Dr. Manish is asking, explain the waving base of ECG kindly. Actually, very good question, Dr. Manish. Can I have your academic introduction write down, please? Till then I will explain. There could be two reasons. Let me check. 9915162832. Yes, this is the number. So there could be two reasons. There could be artifacts. Due to artifacts, suppose ECG machine is placed at near some electronic device and heavy some heavy electromagnetic radiations are there, then it will cause wavy baseline. We call it as artifacts. Or patient is shivering, either a hypothermia, shivering, then even then we will get a wavy baseline. And also in atrial fibrillation, sometimes we will get a wavy baseline. And even in Parkinson disease, we will get this kind of wavy baseline. Anything else want to ask? Today I got only one question. So you can note down my number 9915162832. You can copy this, or you may through which platform you have come. You can just follow back and trace me back. Okay. Okay. So let us. Any other query? मनीष की वेवरी क्वायरी हो गई है, किसी और की कोई क्वायरी है? चलो, let us start the AV blocks. So let me share my screen, and I have created this long back, very good for your remembrance. Let me share the screen. After this, you will not going to forget AV blocks for your lifelong. That is for sure. So AV blocks are of three types, first degree, second degree, third degree. So now let us assume that P is a wife and QRS is a husband. So between them, there is a PR interval. So we can, for remembrance, we can consider PR interval as their relationship bond. Okay. So normal PR interval, here you can see normal PR interval, happy married life. And after some time, this, I don't want to say that, but husband wife get little bit bored. So PR interval, the relationship bond little bit get, newly married couple, difference between newly married couple and those. So with time, this PR interval prolong. So normal PR interval is 3 to 5 millimeter small, 5 small square, not millimeter, sorry, 3 to 5 small square. If it is more than 5 small square, 6 or 7, more than 5. So we will call it as first degree AV block. So you can remember here that after marriage, little bit distance, this PR interval, little bit kept out, but no problem is there. It doesn't need even intervention, any treatment. So second thing is second degree heart block. So here what happened? So here disputes start happening, fighting. It will lead to fighting. So now you can see this PR interval. Look at here. This is gradually prolonging, Mobius type 1. What is happening? This distance get gradually prolonged, and the day wife and husband, there is some quarrel, and this is getting. And one day what happened? There is a quarrel. झगड़ा हो जाता है. So there is a misbeat. You can remember this. But still marriage will continue. Okay. Dr. Devendra, I will tell you to please hold schedule. Let me complete this one. Okay. So you can message me and I will tell you detail. You can even call me. So you can see here, this is gradually prolonging and leading to a fight. You can see here, P wave is not followed by any QRS complex. And then again one P wave occur, and then same phenomena repeat. We call it as a Venki back phenomena. Gradual prolongation of PR interval. As you can see here, PR interval gradual prolonging, and there is a drop beat. After this P wave, we cannot see any QRS drop beat. So we can consider that there is a fight between husband and wife. This gradually prolonged and there is a fight. And again, the same thing repeat. But what happened in Mobius type 2? Just assume when they go to public gathering party, they have to pretend that they are good husband and wife. So here PR interval will remain fixed. So they will pretend in the party. Here you can see figure. So in type 2, they are just pretending they are good husband and wife, and this PR interval is fixed. This is not prolonging, or it is fixed. Okay. So here you can see fight. When they go to public gathering, there will be they are dancing and enjoying. And when they come back to home, again there are the fight. So here you can see the misbeat. Okay. So what happened in third degree heart block? In third degree heart block, the third degree heart block, what happened? P and QRS get divorced. Okay. So now there is no correlation. There is no relation between P and Q. But on ECG paper, we will notice the both because they are living in the same world. So you can see here. So P wave will be marching. Okay. Now atria and ventricle are contracting on their own pace. They have no relation with each other. There is no PR interval. There is complete dissociation of CHB, complete heart block means complete AV dissociation. Now, no impulse is able to pass from the atria to ventricle and total the impulse get blocked. So, atria is P wave, it is contracting on its own, ventricle is contracting on its own, and both are appearing on the same ECG paper. And since there is no synchronicity, so P wave can appear anywhere. It can appear on the T wave, as you can see here. So slightly distorting the morphology of P wave. So if you have to be very keen observer for this. As you can see here. So okay, I will show you in the other slide. I have another slide. So what happened? I have a comparative slide. First degree heart block is very easy. PR is prolonged more than 5 small square. Type 2 AV block is divided into Mobis type 1 and Mobis 2. Here is a comparative slide. Look, PR gradually prolonged followed by a drop. But in Mobis type 2, PR is fixed. PR remain fixed and there will be a drop beat. This is the only difference. Okay. Look, PR, this is drop. PR remain fixed. It could be prolonged, but it will be fixed. It will not be gradually prolonging. It will be fixed and followed by the drop. So after certain number of beat, there will be a drop. Okay. So as the disease progress, drop will become more and more progressive and later will gradually change into 2:1 or 3:1 block. Now CHB, complete heart block. So this I want to explain. This is a little bit difficult to identify. What happened here? Now P wave are there, QRS are there. Both are appearing on the ECG paper, but they are not related. So no, they will not care about each other. So now here you can see there is one P wave is hidden here. Because why we can see this? Just compared with the morphology of other T wave. This T wave, this T wave, this T wave. So here we can see this is tall. So P wave should be here. As we have, I have used cardiac caliper. Na? So if one P wave is there, so one should be here. So it is hidden. So one P difference will be equal and RR difference will be equal. So here P is just appearing before QRS by chance. It doesn't mean this is PR interval. No. After that, it is appearing here. After that, it is appearing here. After that, it is appearing here. And then it is getting sometime merged with P wave, giving it bifid appearance, or may get buried inside the QRS complex. So you have to be very conscious. If you suspect this kind of thing, you look for the all P waves where it could be hidden at equal distance. So we called it as marching P wave. Means P wave will be appear at the equal distance. They could be get buried, hidden inside some complex. You have to find that. And RR interval will be equal. That was important. But these things easy to teach and easy to understand theoretically. And if you have to appear in some ECG written exam, then you can easily pass. But practically, it needs practice, lot of practice. This video lecture or theory will not help, because there are members who have already joined now. They are struggling hard. Not first theory, just sample. Whenever I am giving them sample, because they have joined earlier, so sometimes I post some just to check their course progress. I was posting some ECG, although program not started. From 15th we are going to start. That's final date. Okay. After that there will be not even a single day delay. So whoever who went to join, immediately register, start completing, at least complete 1 or 2 chapter. That will be not very large, small chapters are there, so that you can stay tuned with the ongoing program. Whenever there is a practice session on WhatsApp, you can either attend, or if you miss later, you can check, go through WhatsApp, and you will get a website access. Anytime you can click at the link or log in to website, and you can lesson wise, you can read according to your own convenience. Okay. So there is totally flexibility of time. Whenever you free, you can read. Whenever you watch the tutorial and read the notes, or whenever you need to ask, just post inside the WhatsApp group. So this is the schedule. So weekly there will be one weekend revision Zoom session, and 3 to 4 weekly practice sessions. And yes, even the evening timing. Zoom session will be evening timing at a particular timing, and practice session will also be at a particular timing. Timing will be important. This is not like random. Everything is no. Everything is well planned, and we will decide the timing like 6 p.m. I will ask the member to get gather on a WhatsApp group, and I will be posting some ECG, and member will be telling them, raising their hand, telling the everything will get in a very systematic manner. That you don't have to need to be worried about anything about that. So now a question and answer. You can ask your question if any. You can write down. You can ask.